Good morning. Thanks to the organizers, Kumar sir and Anuradha madam, for this opportunity. And today I will just walk you through why is it important to have liquid biopsy in clinic. In addition to that, we will be sharing our pilot validation study along with some clinical case study experience on usage of liquid biopsy in a CGP approach. So technology is constantly evolving. Medicine is something which we are constantly learning till we are alive on this earth. And I think we are here to adopt this technology as and when it comes, but we need to be careful on what are the pros and cons, what are the limitations of technology, and then take it to the clinic. So on the right side, we have the liquid biopsy or cell-free DNA that is a derivative from liquid biopsy. And what are the sources? Apoptosis, necrosis, and netosis. And you also have sometimes DNA being secreted into the plasma. So we all know liquid biopsy is a complementary approach to tissue-based biomarker testing when we do not have adequate tissue available for molecular profiling of tumors, or when there is a rebiopsy that's not possible and the patient's performance status is not so good. And what is it? It's a minimally invasive procedure. And you can just do it with a peripheral blood of minimum of 6 ml. And the blood can be stored at room temperature for only period of 3 hours if it is EDTA. But if you want to store it for more than 3 hours, we need to move on to a stabilizing solution, that is a Streck tube. And it has been validated by this commercial vendor Streck tube that cell-free DNA is stable for more than 72 hours without further degradation, cell-free DNA being a very labile molecule. So here, what are the potential applications of liquid biopsy in clinic? So now there is this, game changing that's happening where one wants to look at both tumor as well as liquid biopsy based baseline approach to understand the complete molecular landscape of the disease. And it also helps you in understanding when the tumor shreds into circulation, what is the quantified burden of tumor in circulation. And of course, it helps in follow-up. And it helps in minimal residual disease estimation. And when the patient is on surveillance, one wants to detect early relapse. There again, liquid biopsy has a potential. And it also helps not only in profiling classical genomic alterations, it also helps in profiling genomic signatures. So we in our laboratory has been able to profile all the way up to whole exome as well as comprehensive genomic profiling on large gene panels, and we have validated in-house with in-house tools. So what is the important challenge is tumor heterogeneity. It shows here, as you take the needle through the tumor core, you see that some of the mutant clones, each one represents different mutations. Some of them are sampled during the biopsy, where some of them would be left out. What liquid biopsy has an advantage is it gives you a holistic picture of the disease by having most or all of the clones from not only the local site, but also from the metastatic sites released into circulation. Therefore, you get a complete picture of the disease. So what are its advantages? It is minimally invasive, and it can be repeated to monitor the evolution of the disease and also change the therapy while you monitor the disease. Unlike imaging, which is associated with repeated risk of radiation exposure, it has very minimal or no risk while doing a liquid biopsy sampling. And it also represents the complete tumor heterogeneity, provided the biology of the disease allows it to release in circulation. And I must say, it's a submission. It remains only a complementary tool. It cannot be a first-line tool. Tissue biopsy and histopathological diagnosis remains the gold standard for diagnosis of malignancy. It can only work as a complementary tool to address the molecular signature or the molecular understanding of the tumor. So as recent as yesterday, EMQ and ESMO together had released guidelines on NSCLC biomarker test in specimen management, where they have mentioned a section on liquid biopsy, where the aspects which we discussed earlier had been explicitly stated, that we have a role for liquid biopsy when tissue is inadequate to look at molecular drivers. We also have a role for minimal residual disease estimation and response assessment in liquid biopsy. So what are the technical factors that would affect the diagnostic yield of liquid biopsy? How much is the disease volume and its location have an effect on cell-free DNA and ctDNA indirectly, because ctDNA and cell-free DNA is more like a milk and water mixture. It is very, although there are some studies and some publications that talks about cell-free DNA and ctDNA can be segregated, nobody has come up with a robust assay to prove that ctDNA is 100% to the accuracy that yes, the disease corresponds to these many ctDNA molecules. So it is good and wiser to be limiting ourselves to cell-free DNA than going into the ctDNA aspect of cell-free DNA. And in a metastatic setting, particularly when there is a high disease burden, there are studies which have shown that there is an increasing shedding of cell-free DNA, and that indirectly corresponds to higher ctDNA as compared to an early stage disease. So here again, one has to take a call. Is it right to go for a liquid biopsy if the disease is confined? And sample collection, at what time of the journey of the cancer patient we need to collect liquid biopsy, that plays a very, very important role. If there is debulking or surgery already done and most of the tumor has been removed from the body, then the liquid biopsy yield for tumor related alterations would be very, very minimal, or you would be ending up getting false negatives. And so again, last but not the least, tumor biology plays a very important role, whether it is early stage or metastatic setting. Not all tumors release cell-free DNA in the same fashion into circulation, and therefore there is room for a lot of research. And the future is to use the technology of liquid biopsy in different cancer types, but we cannot expect to see a clinical validation that shows 100% concordance at all stages of cancers to say that liquid biopsy is the tool to go forward. Now, there is inter-individual and inter-study comparison, has a challenge, because we know that at tissue level, now we see the same challenge even at liquid biopsy level, and result interpretation and reproducibility. So the result interpretation and reproducibility particularly has a lot to do with the spatio-temporal variation, as well as the labile nature of cell-free DNA, half-life being less than 2 hours. And how do you overcome this limitation? So this is where technology comes into picture. If you have a good technology that is analytically validated, I want to put this quote in quote, analytically validated, that means the assay is good to go. You have verified with reference materials and standards as well as analytical samples, and then you implement that into clinical samples, you get to see answers based on the biology of that particular patient's tumor. But you cannot expect to see a tissue versus liquid biopsy 100% concordant at every stage of the disease, as the journey goes for every cancer patient. So our journey through liquid biopsy and tissue biopsy. So this is the target indigene panel, which we used for validating both tissue and liquid together. It is an indigenously developed panel, which is derived from profiling of 1,500 cancer patients across India, with collaboration with multiple academic centers across India. And it is a comprehensive genomic panel that addresses most of all the genomic alterations that today is used in cancer management, like gene fusions or mutations, TMB, MSI, and copy number alterations. So here is a quick snapshot overview. In any CGP, the design becomes very important where it gets applied to the clinic. Unlike in tissue where you have an opportunity to do both DNA and RNA being used for fusions. In cell-free DNA, the cell-free RNA is something which nobody has been able to reproduce very accurately in a very large scale. Therefore, cell-free DNA is the only source of material, clinical material that remains with us. Here comes the question, can you design an assay that can work accurately to address the technology, as a basis of biology? So the biology says fusions happens in introns. And therefore, if you can sequence the complete intronic region, you are not missing the fusions. And that is where the design of NGS panel comes into picture. So on the top, we have an RNA-based gene fusion where you see the green and red exons joined together and you see the sequences here. On the bottom, you see a DNA-based gene fusion with reads, these reads supporting the intronic region. And if you are able to design a panel where an intronic region can be adequately covered with good number of reads, and if the tumor burden is really good, then your detection of gene fusions or exon 14 skipping alterations or any other alteration that is important in the non-coding region of the genome becomes very accurate. This is just a classical case study from our liquid biopsy. Where you look at, there's a patient with primary driver mutation, and you looked at the tissue as well as liquid biopsy baseline for the primary driver mutation. And upon first follow-up, you see how there is a significant reduction in disease burden post targeted therapy. And this is a very interesting classical example how tissue plus liquid gives you a value-added information as compared to tissue alone when you do at the time of disease progression. So this is a case of cholangiocarcinoma with NRAS mutation at the baseline, and the clinician happened to look at liquid biopsy also at the baseline, and there is a documented evidence of how much is the burden of NRAS at baseline. And this patient came back with disease progression after 1 year. And we happened to look at the first follow-up post therapy, and there is a reduction in NRAS clone. However, there is a new clone that has popped up that is FGFR2 activating mutation, and this turns out to be the value addition that you get from liquid biopsy, which you may not get it from tissue biopsy. So we know that FGFR2 alterations have repositioning options, a level 3 evidence with targeted therapy biomarkers, drugs. So this is one example. Another example I just want to highlight here, the how much of tissue gets into circulation at baseline. So you might see a significant burden of tumor because you are excising, as it was previously mentioned. You have to circle the tumor containing areas, therefore it becomes enriched with tumor. So you would get to see a high allelic burden. However, when it comes to liquid biopsy, it is like a needle in a haystack, right? So there is significant dilution of the tumor molecules, tumor DNA molecules, which have the mutation. Therefore, you tend to see a lesser burden. Here again, not all clones would have a similar proportion of dilution. Some clones might be diluted 1/3 or 1/10, and some of them would be 1/4. So it varies from it. So this is what is all about the tumor dynamics. Quickly on the assay validation on the solid tumor panel, we were able to go to the limit of detection of close to 1% for EGFR mutations. The audience and the interest of the session being non-small cell lung cancer. I'm not getting into the other details here. And this is the another interesting and a very exciting evidence that we found out that not just in CGP, that is the 1200 genes, where we looked at horizon reference standard. Horizon reference is a NIST traceable reference material that looks at all the clinically actionable mutations in cancer at multiple mutational burden. And if your assay is good and you are able to pick up molecules like 1 in 100, that shows that sensitivity is good. Technically, the assay is working. Not only that, I want to draw the attention below here, where we have gene fusions from ROS, RET, and even MET amplification and NMIC amplification. We were able to pick this up on liquid biopsy. And this is just a comparison of performance metrics of the assay at the analytical level. I want to be, reconsidering that it's only analytical. It cannot be clinical for liquid biopsy. And put together, we have a very small study that we did across in this last few months, where we looked at multiple cancer types, both at liquid baseline and baseline tissue as well as liquid biopsy. This is a biased approach because the sample size is very small. However, it's just a sharing here in this forum. What we understand here is the complex biology of the disease across different cancer types is one of the primary factors that defines the concordance between tissue versus liquid biopsy, since not all tumors would release circulating cell-free DNA into circulation in the same fashion. And so the success of precision oncology or targeted therapy depends on how well and how holistic and how comprehensive we are in understanding the molecular spectrum of the tumor. And it depends upon the tumor's biology, of course. Tissue biopsy remains the gold standard. However, liquid biopsy can be used as a complementary tool in clinical practice. And having a combined approach at baseline and subsequent follow-up by liquid biopsy helps in a better management of the disease as per the evidences from the literature. Thank you. And if there are any questions, I'll be happy to take.
Yeah. Thank you, Vidya, for an excellent talk. Like, no tissue, no issue. Liquid biopsy is there for your support. So this talk is open for the questions.
Thank you, Vidya. Excellent talk. So I think, as you rightly said, liquid biopsy is a complementary test to tissue biopsy, and we're not omitting tissue biopsy for sure. But what about the frequency of liquid biopsy during treatment and on follow-up? What do you recommend? The frequency of liquid biopsy has to be done every 4 weeks, 8 weeks, 12 weeks. What is your recommendation?
So there are a few studies which have shown that impact of chemo and radiotherapy on ctDNA burden. So at what time point one has to look at liquid biopsy? There are two ways of looking at it. If we want to define rules, then there is one way. Another way is when the clinician feels that clinically there is a disease progression and he wants to address that without going for an invasive procedure, then liquid biopsy. That is, I think, the commonest approach which most of the oncologists take. When there is disease progression and patient is unwilling to go for another biopsy and he wants to change the management of the disease, then he would go for a liquid biopsy. Another approach, or rather, if you want to understand it more scientifically in the biology standpoint, how a given intervention will have an impact on ctDNA yield, and are we able to detect that in circulation or not? There comes the defining rules of when to sample for liquid biopsy. Ideal way is just before you start the next chemotherapy cycle. There you have adequate impact of the previous therapy onto the patient's disease. Therefore, if you want to understand the current dynamics of the disease, before you want to start a new intervention, you do it just before the new intervention. Therefore, you know the current nature of the disease. That is what many studies have indicated. And of course, other factors also plays an important role. That is the patient's WBC count would have an impact on the overall cell-free DNA yield. And that will again indirectly impact the ctDNA yield. So minimal requirement in most of the NGS assays is 100 nanograms. In general, with a 5 ml plasma, we would get somewhere around 100 nanograms of cell-free DNA in a metastatic presentation. However, if there is a pancytopenia in the patient, the yield would come down to 30 to 40 nanograms. So that would impact the sensitivity of the results, or rather the false negative rate that we would expect to see in the patient sample. In that scenario, how do we overcome? We need to take more blood sample. That's one way, because if we are looking at one mutant against 99 wild type, your representation for 100 nanograms should come from much larger volume of plasma, because your plasma yields are low. Is that answering technically and scientifically, Amit?
Yeah, great. Yeah. So another question to you is that we also encounter scenarios like pseudo progression and true progression on immunotherapy. Will liquid biopsy be helpful in those scenarios?
Well, honestly, I don't know about it. Honestly, I don't know about it, because clinically we have to do that by ourselves. Like somebody has to really look at the liquid biopsy when there is a pseudo progression, because what I understand from the clinic is even though there is a pseudo progression, the clinician doesn't stop the disease intervention management. They continue with the medication. They know that at the end of 3 months or 2 months, depends on patient to patient, they would see a pseudo progression. They will wait for 6 months before they want to see a proper outcome measurement to be done. And if one has to do it, I think they have to do it in a controlled manner to understand what's happening in pseudo progression, probably. Yeah.
Yeah, Dr. Amit, as you have said, as far as lung cancer is concerned, I don't think pseudoprogression is an issue in lung cancer. That is more when you are dealing with a melanomas in which you are giving anti-CTLA4, you are giving ipilimumab drug. So in lung cancer, if there is a progression, you have to take it as a progression. That's what we have learned in our tumor boards. Okay. So that's not an issue in lung cancer, very, very rarely. Okay.
We did come across one case like that, where pseudo progression was there in a small cell lung cancer while profiling. It means that the indication was mentioned, pseudo progression on immunotherapy, and there is a fear because already small cell disease is having poor prognosis. Patient lives less time, right? So that's when I think the doctor wanted to do a biopsy and quickly check what's going on to look at new alterations. So. Yeah. That's but in non-small cell probably that's not a challenge at all.
Even if we are anticipating or if there is a dilemma, but eventually it turns out to be a true progression rather than a pseudo.
Okay, sir. Thank you.
So Vidya, I'm Dr. Mehta. I'm online. Hello, can you hear me?
Next, I call upon Dr. Trupti Pai, who is an associate